Good morning, Dr. Bali. Can you hear us?
Good morning. How are you?
Good morning. Very well, sir. How are you? With me here, I think Arun just stepped down. I've got Dr. Tiwari and Dr. Kasturi on either side of me here. Welcome to TCT South Asia 2023. We're excited to see your ultra-low zero contrast complex PCI case that you'll be doing for us.
Good morning to everybody. We have Dr. Naveen here, and we have our entire team here from Paras Hospital. And Dr. Naveen is going to present you the case today.
Yeah, can I have the slides, please, from outside? We have this 83-year-old gentleman. He is 182 centimeters, 85 kilograms. He's an old patient of diabetes and hypertension. Both are well controlled on treatment. And he's had post PTCA to RCA way back in 2015. And now he came back to us with gradually progressive effort angina for the last about 3 months. So we did an angio last, this is 8th of July, which showed LMCA plus triple vessel disease. So on 8th of July, we had done his PTCA to RCA with cutting balloon, IVUS with OCT guidance. And today, what we are planning is left main bifurcation lesion addressing. And the left main, we'll just show the...
Can we have the angio, please?
Can we have the diagnostic angio, please, here?
May I know who is on the dais, please? Who are the panelists we have?
Yeah, good morning, Dr. Sridhar Kasturi is here.
Hi, Dr. Kasturi, how are you?
Yeah, there is a LB dysfunction and the GFR is low. Are you using the intravascular ultrasound?
Yeah, we're using the intravascular ultrasound.
It is about 40%.
Plan is to go with a low contrast PCA because the GFR is only 43%.
Yes.
There is significant LB dysfunction.
So do we have the scout angiograms, Dr. Bali?
Yeah, we're just showing you the angiogram. I'll just show you that.
We'll see
we have the angiogram,
angiograms so we see precisely what we're treating.
Can you show us the angio, please? Or can you focus on the lower
Can I focus on the lower screen, please?
Is this lower screen visible?
Can you
Can you
show the
see-
angiogram films
No, what
first?
we see is the hemodynamics, which for what it's worth show blood pressures of almost 200 on 100, which I think is one of those things that we can talk about a little bit in a setting of zero contrast work.
We'll see the angio.
Presuming those are zeroed. We don't see the scout angiograms though.
Yeah. Can we see the angio? Second screen, lower screen.
Yeah, angiogram films.
We're just showing you an angiogram now.
Dr. Bali, we are not able to see the angiogram.
Just showing the angiogram now.
Thank you.
Or you can tell.
Can you, we have a
Very
distal
good.
left main and we have a bifurcation lesion. The circumflex is a non-dominant vessel, about 2.5. There is a acute band at the origin of the circumflex. And then we have left main distal disease, and we have an ostial LAD about 80%. And we have a mid LAD, which is heavily calcified lesion, and it is about 85 to 90%.
So severe disease in the proximal segments.
Can you see the
presumably-
angiogram?
Yes, we can see the angiogram. Lots of tortuosity distally.
Yeah.
We'll play that one more time. Maybe the next view you were showing us, the
Yes.
caudal view.
Yes. Can you go to the next view, please? Yeah. Can you see
Yeah.
this
There we
view?
go. This is an
Yeah.
excellent view. Okay. So we can appreciate the severe disease in the mid LAD beyond that large diagonal. We can appreciate some of the calcification. We appreciate the distal tortuosity of the branches
Yes.
and the slow flow in that ramus that you see with that critical lesion very proximally. The angulation of the circ. Next view.
Yeah, circuit.
Can you show the next view?
The distal RCA is.
There's a distal RCA
Yeah, that
CTO with
RCA
some
has
great
been-
RCA has been
visualization.
fixed in the previous on 8th of this month, and we have
Okay,
done,
good.
that was a CTO RCA. We
That's
did an
been fixed.
angioplasty stenting of that, and we got a very good result about that. So that part is fixed. So now we are planning to do an LAD and left main, and we have to take a call whether we go for a bifurcation lesion here because it's a 2.5 millimeters circumflex and it is a non-dominant vessel, not very big. So, but it's disease at the ostium. So I would like the panelists to tell us whether we should.
Do you
We
have
a
a
little
caudal view?
difficulty in wiring this circumflex because of the acute angle we have.
Can you show us the AP caudal view?
Yes. Can you go to the caudal, please?
Can you come to epicaudal, please?
We'll just show you do an angiogram and show you that. So we'll use a small contrast to show you an angiogram. Okay.
So very complex lesion subset, mid-LED
Yeah.
calcified, left main distally involved, trifurcation with a critically diseased but
Yeah.
decent sized ramus, and an angiographically modest sized circ, though we know that the
Yes.
angiogram can lie to us, particularly in the proximal vessels.
It's almost trifurcation lesion. Even ramus also appears
Mhm.
to be
Yeah,
a reasonably big sized vessel.
agree,
And we should
Agree.
pay attention to that one also. Again.
Would
agree.
you like us to do a bifurcation or do a crossover from LED to left main and then see if this circumflex
Can
ostium
we see
shows-
that caudal angiogram? The only one that we got was the LAO
Yeah,
caudal. There we go.
epicaudal.
Can we show an LA caudal, please?
Okay. So I think that's a decent sized circumflex, to be honest. And
Yep.
I think it's very difficult to figure out what the nature of the disease is in this challenging situation. But this is a low contrast PCI, the hallmark of which is the use of intravascular imaging to see differently. And so I think the approach would be to try to apply the definition criteria around complex
Wait,
bifurcations.
I'll just show you an angiogram in the LA caudal.
Sure.
Hmm.
Specifically by using intravascular imaging to define whether or not you actually have disease. Certainly looks like you have disease at the proximal circumflex. It looks like it's about 8 to 9 millimeters long. The angulation is big though. And as Dr. Kasturi pointed out, it looks much more like a functional trifurcation with that sort of ramus high OM being involved.
Yes, yes.
Actually, this case, because it's a retroflex, if you see the angle of the LCX, it's very difficult once it's
Yeah,
closes.
That is the reason why we're having a little problem with the wiring because
So
of the complex
wiring,
design.
and at the same time, I prefer a jailed balloon technique in such type of cases
Mhm.
to protect the LCX. We use the like a plug modification of the LED, LM, and subsequently when we are provisional should be fine, but at the same time we should keep even sometimes it's difficult because completely the angle is unfavorable. So that time if you keep a very small profile balloon for jailed balloon technique, that works well for this
Sure.
patient. That's my opinion.
And another option is it looks like you're able to get into that tightly diseased ramus branch. And so putting a
Yeah.
wire into that and then taking a dual lumen catheter along that and then
Rewrites
wiring
the
retrogradely or wiring retroflexingly into the circumflex is also reasonable.
Yeah, we can do that. We can do that. We
Right.
can do that. I'll just change the angle of this wire a little bit and then see if we can
Sure.
get through that. And,
Did you-
try it
did-
for 2 minutes?
So presumably you're doing this as an ultra low contrast sort of intervention, given the
Ye-
patient's underlying
yes,
kidney
yes.
disease. Did you get an LV-EDP at the beginning of the case?
We had got last time, it was about 18, so it's
Yeah.
not that significantly
So it's-
dysfunction.
It's one of those
about-
things that begins, that's what really begins the zero contrast or low contrast protocol, right? Is the LV-EDP at the beginning to define peri-procedural hydration per the Poseidon protocol, though we see the blood pressures in the lower right-hand corner of your vital screen. And so you're almost certainly going to have high LV-EDPs in someone with that level of hypertension. So, I mean, Dr. Tiwari, would you try to get the blood pressure down a little bit and then decide on
Yeah,
peri-procedural hydration?
I think it is touching around 200.
it's about
so-
200 over 90,
Yes.
200
Can we
over
start
100.
Definitely.
Start NTG.
So at risk for
Because-
pulmonary edema with occlusion of
very
the
high.
proximal vasculature
Yeah.
with those kinds of blood pressures, you almost wonder about getting the blood pressures down.
Sir, are you
and then
checking the
deciding.
IVUS plaque burden assessment of the LCX? Because to decide whether one stent or two stents, if you see the
Yeah,
plaque burden,
I have a little difficulty in getting into the circumflex because it keeps on going into the OM. I'll just change the angle.
Which wire you
So
are
let me
using?
try for a
The
minute
wire-
and then we'll
Wire
see.
you are
Short
using?
And what wire do you have?
We have a BMW in the LED and I'm going to use a Schwann blue into the circumflex to give us a little support.
Okay, well, you had the ramus.
Yeah,
Yeah,
I have the
the
Remus, but I
The
don't.
Remus is going repeatedly, but it's not getting into the main cell.
I
So
would
I can-
recommend you to use filter XTR. This will be very easy across into
Yeah, I
the
use a field
Yes.
XT, but
filter XTR.
can you give me a filter XTR?
Filter XTR there is.
sir, in such case, even supercross also helps. If you
Yeah.
angle the catheter, another one.
I think the
Two-side
supercross is
also-
probably your ideal
two-side also
ideal
you
mitral
can change the
catheter.
wire and put one into the ramus, one into other angles.
That looks like it's going somewhere good.
Fully agree. I mean, like, I think Supercross for some reason hasn't gained a lot of traction in this part of the world, but like the 120 and the 90 are
It's a
incredibly
very good
useful for
catheter
retroflex.
for exactly this. And here, I mean, the challenge is the core of the wire, right? If you look at the bend as you come around the corner. So having any microcatheter on this to give yourself some support and a base that you can work with is, I think, going to make your life a little bit easier.
If you're going to use a dual lumen, as I think Sanchak pointed out earlier, perhaps
We have an
find the
angled
one that you
microcatheter?
get the Ramus,
Give
put
me
a
an
The
put a
Ramus,
dual lumen over that and try.
gently dilate it because you're probably going to stent over it anyway. And then maybe even DCB it proximally and think about how you're going to then address the main circumflex. All of that's going to help you wire it.
I'm going to use an angled microcatheter and see how it works out.
Super, super. Which one are you going to choose?
We have a
Yes.
Supercross.
Use your
We have a
Supercross
Supercross.
120?
We have a Supercross.
Yeah, that's a really good microcatheter. I think it's important for the audience to recognize what these angled microcatheters, though, is their purpose is to help you direct the wire. Their purpose is not to provide you a base of operation. So those are not the microcatheters you then advance into the target after the lesion, because the angle in and of itself makes the microcatheter very difficult to advance around the corner or through critical
Field
lesions.
XTR.
Get the
Field
wire
XTR.
where you need it to go, take the microcatheter out. And
So we are going to use a filter XTR and then I'm going to use the microcatheter and see how
Sure.
it works out.
Sure.
Sir, as per the guidelines, difficult to access and angulated branches, whenever there's a bifurcation lesion is there, particularly block burden is more difficult, provided if you are accessing the side branch, preferable to go ahead with the side branching stenting first to make it much more simpler. What is your strategy about this case, sir?
Yeah, my strategy is that we would like to stent this circumflex first because there's a difficult access. So we will primarily try to go with a bifurcation stenting if we can get the wire into this. Because
we're all
it may be
leaning
a
in the same
little
direction.
tougher getting into the branch after we have stented the main branch. So that's what my plan is, but let's see what the panel says.
I think we're all leaning in the same direction. It looks like that's a real circ. It looks like the angulation is difficult, and so you're going to want to secure it. But the point is well taken in that it's worthwhile trying to understand what the nature of the disease is in both branches using intravascular imaging so that you can apply the objective criteria that we have, right? And then this is one of those ones where now in the world of wide availability of drug-coated balloons, where you think about using a DCB in the proximal part of the circumflex as a way of avoiding metal at that ostium, but still treating the proximal part of the vessel. And obviously, we don't have the data there to tell us what's right.
Yes, we
Very
have got
good.
it.
Very
It's a wonderful, actually,
Very nicely done.
beautiful demonstration of the supercross usage, particularly angle vessel, how to access.
Beautifully done. Beautifully done. So now you'll, I'm sure, take out that supercross,
Yes.
trap it out, and then take a regular catheter down and perhaps change that fielder XTR to a regular workhorse wire that's safer in the distal vessel.
Sanjog, sometimes if you can adjust your guiding catheter,
Absolutely.
make it little more straighter,
Mhm.
pull into the left main.
Mhm.
So then you can sometimes
Okay,
negotiate.
let me see if I
into
can
the
get the microcatheter a little
think
beyond
the-
it to-
The other thing that's worthwhile noting is that we see how quickly and how efficiently you were able to cross into the circumflex with the right wire.
No, I'm
and the
going to
right
change it
microcatheter.
to a normal wire. Okay?
Yeah. So it's
Yeah.
it's one of those things where you see how easy it was to use the right tool to address this problem. We're rich in interventional cardiology now, and that we have so many good tools for these challenging cases. It makes sense just to save the time, save the patient the radiation, save the procedure ischemic burden, and just use the tool early, cross early, and get your case done. Here, I think it was a perfect demonstration of where this tool was just the right tool for the job.
So just to tag along with to what Sanjog was saying, it's also really important, as experienced as Dr. Bali is. Now he's switching his CTO wire, like the wire that was used to get into the circumflex. Although it's an XTR, it's got a tapered tip. He's now switching to a workhorse wire. It's going to give better support, and it's also probably going to be
It's a lot
more friend. It's a friendlier wire, right? It's a lot safer.
You know, I think the idea of wires in general, there are people then who will talk about safe wires and not safe wires. I think in the hands of a complex PCI or CTO operator, there's no such thing. Every wire is a square peg, a round peg, a triangular peg. They each have their own characteristics. They're meant for specific problems. You solve the problem and then you switch down to your sort of more comfort, relatively predictable wire behavior type of wire. And so it's more about matching tool to task than it is safe or not safe, which means you stay away from the stuff that you don't need for a particular task. And by extension, you use what you need only for the task that you need it. And then you change down back to something that is more workhorse related.
Now I'm going to dilate the ostrom of the LED and the mid LED a little bit and then do an IVUS. Would that be okay?
Yeah, we'd like to see the IVUS of both the LED as well as the proximal circumflex.
Yes, please. LED 2.2.
So
mil-
you've got a
2
very tight
millimeter.
calcific lesion in the mid LED. What's the strategy you're choosing? Or are you going to wait for the IVUS to tell you?
Yes, we'll do an IVUS and then decide.
I think that makes great sense.
Considering the LV dysfunction, I think we're more inclined towards an IVL, but let's see how does the IVUS show.
Sounds good. Maybe we'll let you do that and look forward to coming back to the IVUS images while we. Hi, Dr. Bali, we're back with you, and you're.
Yeah, we have a little issue there, and problem is that
Wow.
I couldn't get the IVUS catheter
Oh, yeah,
across.
we
into
can
the
we can
LED,
see how
we
terrible
dilated.
that angle is. Goodness gracious. Oh, that's very difficult. Do you have access to a wiggle wire?
No, I don't have wiggle.
So that's an old but very good wire. It's an anchor wire with a very stiff core that can help you around these extreme angulations. The downside being that it will create pseudostenoses if necessary.
I'm trying to get that microcatheter again if I can get. Oops.
And your guide catheter is coming back, looks like as well a little bit.
I think extreme angulation, guideliner backup also helps in this case with the guideliner with microcatheter access.
Yeah.
That also helps.
Yeah.
But already you have placed the wire. I think if you change the angulation, it can give a good support and you can park distally. And subsequently put the guideliner for backup because calcification, severe calcification.
What is the microcatheter that you're trying to advance, Dr. Bali?
I'm taking a supercross again.
It's the same supercross. We're trying to get around that angle. Do you think just a regular sort of fine cross might be a
That's-
little bit easier to get around that corner?
That was the reason I was asking. You already have the wire in. Perhaps something like a fine cross
Maybe
might be
something
easier
that-
to deliver.
a little bit easier to deliver
This might actually backfire.
Okay.
because
Let's
you've got quite a nasty angle on the wire there
Okay.
around that circumflex ostium.
Okay,
It's going to make your
normal
life very
microcatheter.
difficult. And the worst thing you'll get then is a kink in the wire where then you can't deliver anything and you've got to start all over again. You're right at that transition of the core to the radio-opaque segment, which is the least
I
supportive.
could take a 1.5 balloon and see if it gives me a support, but
I think, again, this is about picking the right tool for the task, right? So you can try the 1.5 if you want, but you know,
Yes.
what we want is something that's going to be an almost guaranteed win.
yes,
Because at
let's
this
take a
point, you're in
microcatheter.
danger of
Let's take a
losing the wire.
microcatheter.
Slightly
Right.
looped into the LED. So because that when you pass the like
Yeah.
This is
like a
the-
power and anything,
Okay.
definitely
Yeah,
it will
you-
not. Only
you can-
caramel or fine cross will be helpful in this.
You can use a push-pull technique here, where as you advance the microcatheter, you tug back very
Negative
gently on the
traction.
wire. That negative tension on the wire will allow that microcatheter to negotiate that curve. And then once you get it around the curve, you've won, because then your wire just goes.
Fine cross. So I'm taking a fine cross and let's see.
Yep.
And then try that pull push technique and see if I can get that.
I think for the audience, instead of focusing on the maneuvers, the wires, you have to tackle the bend. That is more important because once you solve that problem, then it's easier to maneuver the wire.
Yeah, that's where the whole wiggle wire piece
Yeah.
or some sort of a supportive wire comes in. So that's the other thing that's probably worth discussing here is as you come around the corner and get this wire back down with a fine cross that will hopefully negotiate that turn, is it time to put a more supportive wire down the circumflex to give you a backbone? Something like a Grand Slam or a BHW.
Yeah, if I can get this microcatheter across, then I think I'll try to put in a Grand Slam.
It'll be interesting to see if the Grand Slam actually negotiates that bend because it's truly retroflexed. Here comes your
Moment
fine
of
cross.
truth. Okay.
Just pulling the wire back.
There you go. Do you want to change the,
Yeah.
oh, there we go. There we go. Here we go. Do you want to change the angulation slightly so you can see
Your
it?
guide is backing out.
Yeah, your
Just be
guide's backing
careful.
out
Your
there.
guide
Just
is
be
backing
careful.
out.
So maybe pull the
No,
microcatheter back
I
a hair.
I
Get
think
the
the
wire
mic-
back down.
Oops.
Ooh, careful.
Once again.
I think I'll have to wire that again.
I think
I
so
you're
too.
probably
Yeah.
there. Oh,
Oh, maybe
nice
not.
save.
Good save.
Nice save.
Maybe. Maybe. No,
No,
you're right.
don't take that, man. Yeah.
Nice,
There you-
nice, nice, nice. Well done.
Dr. Bali, before you advance this, do you want to
Yeah,
secure
let's-
your guide?
Yeah, let's
Like, you
get
know,
your guide back in.
get your guide
before
back
you
in. Perhaps
that
that
down.
might help.
You've got a lot of tension stored in the guide. I'd also come down to an AP caudal view so you can see a little bit better how far along the corner you are. Because at this point, I don't know if part of the angle that we're seeing is actually bowing of the wire into the LAD, or if that's actually the angle of the circ. Because when you actually get the microcatheter partway around, it straightens out a little. And it may be that you already have a kink there, and that's what's preventing you from getting around.
Possible. Are we in the LED?
No, I think the wire is looping and I'm not.
Do you want to bring us AP caudal for a second?
Yeah,
Can you bring
yeah.
us
Give me
AP caudal for a
AP caudal.
second, just before you advance? There, see, do you see how the angulation looks different now? So we can bring our guide catheter in now.
Oh, Very challenging. I mean,
Very
obviously,
challenging
yeah.
angulation.
Okay.
Yeah, it's just it's getting around.
We let it go wherever it goes.
He's very close. There you go. I would have no problem with the distal wire here. It's in an
Yes.
atrial branch. It's
It's in
fine. Let use that little bit
There
of
you-
extra support
give me
before to
the
get the microcatheter in.
No,
And then
there's a little bit of loop there.
So
yeah,
I
see,
just
it's
wish-
bowing into the LAD here.
that's
Yeah.
way into the LED.
Yes.
Yeah.
It would suggest to you that there's
Yeah,
an
it's-
issue with
it's
the
a-
wire
it's a
core
big
and that you've got a kink
Bend
or a
in there. All right.
in the wire. And the other way you're going to get around that then is by forcing. There you go. Okay.
Yeah.
Now you've got hope of getting it around.
Right.
Nicely done. Yeah. Now you got the core of the wire. Very well done.
Sweet.
Very
Great
nice.
save. Nice job.
Nice
Well,
job.
I'll put in a grand slam here.
Nice job. So that was a difficult save.
The other issue is that I couldn't get the IVUS into the LED, so we're going to use. I dilated with 2.5 millimeter balloon, so I'm going to use a cutting balloon there in the LED, so I can get the IVUS into the
Sounds good.
distal LED. So I'm going to put in a grand slam into the OM. लगा देना डॉक लगा देना डॉक लगा देना Okay, I think
That's a grand slam, Dr. Bali.
yes, that's a grand slam, and I'm going to put a cutting first into the LED and then see
I think
Cutting,
absolutely on
2.5.
board with you on that.
2.5.
Sir, I personally feel initially dilate with a small balloon, then put the cutting balloon. I
We,
think
we dilated that. We
Excellent.
dilated with 2, then
Dilated.
2.5, but still I can't get the IVUS across. So that's why I'm going to now put in a cutting balloon. We have dilated it with the 2.5.
good.
And the angiographic projection here isn't great, Dr. Bali, but like, do you think the fact that you can't get the IVUS in there is a question of angulation? Is it calcium or a combination
It's a
thereof?
lot of calcium because whatever calcium we could see, it is almost 270-degree calcium. It's a long segment calcium.
So you're fighting two battles here, both extreme tortuosity and
To have experts like
Calcium.
you guiding me is a great, great help.
you're doing all the work. You're just the peanut gallery here.
It's a pleasure talking to you.
That was a really nice save, right? And I'm sure that, you can describe at some
2.5.
time later how moving the wire down onto a different part of the core is what allowed you to get that microcatheter around the corner of that nasty angle. Because you were
Great.
repeatedly bending into the LED and then it gave you the opportunity to switch over. So now your plan will be to dilate the LED,
Yes,
maybe
please.
dilate the ostium of the circ as well, make yourself
Yes,
some
yes.
room,
I have
change
dilated the
angle,
circ.
and then
I'll
do the-
dilate it again with a cutting because it's a nostril circ.
Yeah.
But first, let me
This is,
dilate.
this is
the,
all telling
LED.
you that you've got disease at both ends and you're going to be committed to some sort of treatment strategy that's going to address both vessels.
Absolutely.
So Dr. Bali, it's 11:30 here. We're
Okay.
going to move to one of the talks just to kind of stay on time.
Okay.
But
Okay.
once you're done dilating, we'll come back to you shortly thereafter to
Okay.
look at the IVUS and then discuss your strategy. And perhaps later on in the day, then we'll be able to see the final result.
Okay. Sure. Sure. Sure.
Dr. Bali, we're with you here.
Yeah. What we have done is, we done cutting balloon into the LED, and we done cutting balloon 2.5 into 15 bovine into the circumflex ostium, and then we have taken an IVUS, and we'll just have show you the run of the IVUS. And there is we have marked the distal end of the lesion, and there's a heavy calcification, and there's a nodule, and there's a 270-degree calcified nodule, calcified block. And it shows a few cutting, which are a result of the cutting balloon. And I think I'll just tell Prashant to tell you the IVUS finding. And now we're doing a IVL, and he will read out the IVUS findings.
We're pulling back about 2.5 millimeters in diameter, a little bit of calcification coming towards the bottom of the vessel. 180 degrees there as you continue to pull back. Ooh, there's a little bit thick, a little bit more important volume of calcium here. Obviously, you can't tell thickness precisely with IVUS, but you've got a lot of dropout over 270 degrees. So it's a calcium score of at least 1, depending on how long the calcium is. So is it more than 5 millimeters that you have that kind of calcification?
Oh yes, the calcium is along the entire length of the lesion, more or less.
Right, but the 270-degree arc, how long is that?
270-degree arc is the length of the arc, 270 degree.
And you do have a nodule there as well.
Yes, please. There's an arch.
So the 270-degree looked like it was less than 5 millimeters, but you certainly have a nodule, which is a point of 1.
That's a huge nodule there.
And there's some more calcium there. Yeah.
Any areas more than 270 degree.
And the distal left main also has
This is
calcium.
also more.
Right. So, but it's important to note, right? The calcium score that was validated by the CRF group, Kiko Miyahara and her group wrote it, was a 360 degree of calcification for any length, 270 degree for 5 millimeters, the presence of a nodule, and the presence of a vessel that's less than 3.5 millimeters. So distally, you have a vessel that's less than 3.5 millimeters. You have the presence of a nodule, so you have a calcium score of at least 2, which means you're going to need some sort of calcium modification technology.
Yeah, we're already
In
doing
that
that.
study,
So
it
we're
was
using
atherectomy.
IVL here now.
We chosen a 2.5 millimeter IVL because the distal vessel is LED is 2.5. Yes, please. And this is the last pulse we're giving.
It's interesting. We see now, I presume it's because you have a lot of stuff inside your guide catheter,
Pressure.
but your pressure is a lot lower than it was. I'm not sure if that's just dampening because of the
Yeah, a little
amount of stuff
dampening, and
in the
I think it
guide,
should be. Yes,
but
please.
it's almost 50% of what it was before.
Yeah, we did start NTG for some time.
Okay.
And I think the pressure should be back. So what we decided is that we'll stent the LED, mid and distal LED, just distal to the ostium of the left main first. And then we'll do a bifurcation stenting using a DK crush, if that's okay with you.
That sounds like a great plan.
Sounds like a great.
Did you happen to get the IVUS into the circumflex after pre-dilating it?
Yeah, we couldn't get that. We tried to do that.
Not
The angle
surprising.
is so good.
It's likely though that you'll be able to do it after stenting in case that angle then straightens out a little
Right.
bit.
And what we decided, I put the circumflex wire into the distal circumflex, and we're going to stent only the proximal part, just proximal to the OM. If that's okay with you, and then do a DK crush. So first I'm going to put in a 2.5 into 33 millimeter stent into the LED, just beyond the bifurcation.
That's great. So we'll let you do that stenting, and in the meantime, we'll have Dr. Punamia come up and speak to us about laser and
Yeah.
CTO PCI, and then come right back to you.
Sure.
We're going to jump back to Dr. Bali just for a quick second to see where he is and see if we can define his final result before we conclude the session. We're a couple of minutes over, so just in the interest of time, we'll jump back there very quickly to give him a last few minutes to define what he's done. Dr. Bali, we're back with you for just a couple of minutes to see where
Yes,
you are.
that is great. And what we have done is we have deployed a stent in the circumflex. When you left us, we did a LED angioplasty stenting distally, the 2.5 millimeter and 33 millimeter stent. And then we put in a stent into the circumflex ostium, 2.75 millimeter into 18 millimeter. And then we crushed it with a 3.25 millimeter stent. And then we rewired the balloon circumflex, and then we did a kissing balloon angioplasty of the distal left main, circumflex, and LAD. And after that, this is a kissing balloon, you can see. If you can go previously, we can show you the stenting. I will just show you the stenting part. Yeah, this is a stent we deployed, and then we crushed it with a 3.25 millimeter balloon. 3.25 millimeter balloon, high pressure. And then we rewired it across with 2.2 millimeter balloon. After that, we did the kissing, 2.75 and 3 millimeter. And after that, now we're putting in a stent into the left main to LAD, and then we recross it. And so I got about 30 millimeter? 30 millimeter. I've got a 3.5 into 30 millimeter balloon, and we're going to do into a stent into the left main into LAD. And your comments, please.
Sounds like a really nicely done bifurcation.
Okay.
I'm just
With the
excited to
test.
see what it's going to look like,
We'll test.
as I think we all are.
Okay. Yes, we'll just check up that the stent is overlapped.
Epicranial.
Yeah, we are overlapped quite nicely. Yes.
Wonderful.
Okay. And now I'm going to deploy it. Okay. Look, we are not covering the ostium of the left main because the left main ostium is healthy. So we can give an allocaudal. Give me allocaudal.
What did you say the size was of the stent that you're using to cross over?
Crossover using 3.5 millimeter into 30 millimeter. 30 millimeter onyx.
Great.
And then we intend to do a part with 4.5 millimeter.
Right,
Test.
yeah. 3.5 will go to 4.5 on that platform
Yeah,
with these.
Yeah, that's it. Okay. We can take it to where or keep it. So this is onyx 3.5 into 30 millimeter. Okay, put it back to 12.
We had once again impressive decrements in the hemodynamics over the course of the case, where we started at pressures of 200 on 100, and now we're seeing your pressures are substantially lower than they were before.
Yeah, they do drop whenever there's
Momentarily,
a
they were up to like a bit earlier, there was 150s. So it's like, it's just gone.
Can you give me a
Wonder if some of
4.5
that
into
is
12 millimeter?
When they're inflating in the left main, I think it.
All right. And just to conclude then, hopefully we can get a final picture from you here, or not quite final, but close to final picture to show us the results of your good work. And we'll then.
Yeah, we have to do a pot and we have to do another kiss and then do a repeat pot.
All righty. Okay, just in the interest of time, Dr. Bali, I think we have to conclude this session.
Okay.
I know you're doing this as low contrast, so I don't want to force you to take another picture right now.
Okay.
Maybe we'll come back at some point later on in the morning and be able to look at your final result.
Okay. Okay. Give me 5 minutes back and you can come back at any time.
All righty.
So the Dr. Bali wanted to show 1 minute the final thing what we said. Dr. Bali, we can see you. Just briefly, quickly
Okay.
finish. Okay.
Good afternoon. So when we left you, we were deploying that left main to LED stent, which was a 3.5 into 30 millimeter. And then we deployed that and we did a first pot with a 4.5 into 12 millimeter balloon. And after that, we recrossed the circ and then we recrossed the circ with a wire, did a 2 millimeter dilatation, and then did the second kissing with a 2.75 into 3.25 millimeter balloon. After that second kissing, we did the pot with a 4.5 into 12 millimeter balloon again. And then after that, we optimized the distal part of the LED stent also with a 2.5 millimeter at moderately high pressure. And then we repeated IVUS here into the LED into left main. And IVUS, Prashant will show, we have got a very good result. The stent is very well optimized, and deployment is nice. And we got a pullback right till to the left main ostium. And we have an area of 3.5 into the 3.48 into the left main, 13.48 into the left main. We have 10.56 into the distal left main, and then we have about 8.6 in the proximal LED. And the stents are nicely deployed. There is no dissection. There is no under expansion. So we did a check angio. So we finished with about 30 ml of dye in this entire procedure. And we got 2 angios at the final end. So IVUS shows a very good result in the LED left main, and there was some technical challenge getting into the circumflex with the IVUS catheter. So we thought we can leave it. So IVUS shows very good result into the left main LED and nice deployment. And as you remember that we did a block modification with a cutting balloon and an IVL balloon. So we have got a good result. And if there's any questions,
Thank you. Thank you, sir. Great result, and a round of applause for him. We are running slightly behind the schedule. Again, game-changing technology, low contrast, zero contrast. I wanted to have one of those cases. Thank you again for sharing that.
Thank you, and best wishes for the conference. And
yeah,
best
we have
wishes from
Dr.
my
Ajay
entire
Kirtan.
team.
We have Dr. Ajay Kirtan sitting and saw your now brief presentation. Thank you, sir.
Ajay,
Okay.
good afternoon.
Good afternoon. Very nice job.
Thank you. Thank you. And bye.